So hi everybody, thank you all for joining us for this webinar, which is part of our series of presentations being delivered on applying evidence in practice as part of the Comorbidity project, which is funded by the Australian Government Department of Health. My name is Christina Morell. I am a Senior Research Fellow and Program Lead of Treatment and Translation in Complex Populations at the Matilda Centre for Research in Mental Health and Substance Use at the University of Sydney, along with Erin Madden, who is a project officer on the Comorbidity project, as well as Professor Catherine Mills today, who is the Director of Early Intervention and Treatment Research at the Matilda Centre. I had the very great pleasure of facilitating this webinar, which is being presented by Jo Cassar. Before we start, I would like to acknowledge and pay my respects to the traditional owners of the lands on which we're meeting and recognise that we are meeting across Australia today. The traditional owners of the lands that I'm currently on are the Gadigal people of the Eora Nation, but I would like to pay my respects to other traditional owners of the lands across Australia for everybody else who is here. I'd also like to recognise and acknowledge the many people with lived experience of mental illness and substance use, as well as their families and carers, many of whom have very generously contributed to the development of the Comorbidity guidelines, as well as our other resources. So if you've been to one of our webinars before, you would have heard this already. Please feel free not to listen to this little bit and come back in a minute, but everybody here, I'm sure, is very familiar with Zoom. Just to quickly go over a couple of things before we get started. Just to let you know whether you're attending live or watching a recording, we can't see or hear you, you're in listen only mode. So just wanted to draw your attention to the Q&A and chat buttons on your screen. Please feel free to click on those and type in any questions you have, or the Q&A button in particular, at any time during the presentation today. We will have some time to go through as many of those as we can at the end of Jo's presentation. If you have any comments or any questions for Erin and I or Kath that is not for Jo, please use the chat. This just helps me and Erin filter any questions for Jo and any other general comments. If you have any technical issues during the webinar today, you can contact Zoom support, or you can access the recording of the webinar, which we will be making available, as well as the PDF handouts of the slides from today. Those will both be available to download from the website on your screen there. If you find Zoom chat distracting, you can have a little bit of a play around with the settings on your end to disable the messages that you see. To do this, you just need to have a little bit of a fiddle with the Zoom desktop app if you have it installed. So click on the setting wheel in the top right-hand corner of the screen, select chat in the navigation menu, and then you can change the messages you see. So to do that, the link to do that, sorry, is on the screen there, and Erin can also put that in the chat. So today's webinar is focusing on treating co-occurring substance use and mental health disorders using tools from CBT. And I will hand over to Jo to get started in just a second, but just before I do, I wanted to quickly mention our upcoming webinars, which you can find out more about and also register for at our website. The link to do that is on the screen. And thank you very much to everybody who's been coming along to the series, either watching live or watching the recordings later, and also sending through feedback and suggestions for future webinars. We do ask for suggestions at the end of each webinar, and today's topic, as well as the next two, have actually been organised in response to your feedback. So please do let us know if you have any suggestions for future areas that you'd like to see as part of this series, and we will see what we can do. So now it's my very great pleasure to stop rambling and introduce our presenter for today. So Jo Cassar is a clinical psychologist who has been working in research in clinical settings for the past 14 years. She's currently working as a therapist on the COPE-A study at the Matilda Centre, treating young people with substance use issues and trauma. If you've been coming along to our series, you might remember that Kath Mills and Logan Harvey talked about the COPE-A study in one of our webinars a few months ago. Jo also works in private practice and enjoys the balance of research and broader clinical work. I've known Jo for many years, but have never really had the opportunity to hear her present about her work and experience before. So I'm really excited that she was able to come and present today and learn more about her expertise. So I will hand over to her to get started. Thank you, Jo.
Hi, my name is Jo Cassar. I'm a clinical psychologist and I work at the Matilda Centre for Research in Mental Health and Substance Use, and I also work in private practice. Today I'm going to be talking about treating comorbid mental health and substance use disorders using tools from CBT. We're all coming together from different parts of the country today, so I'd like to begin by acknowledging the traditional custodians of country throughout Australia and their connections to land, water and community. I am currently on the land of the Gadigal and Wongal peoples of the Eora Nation, and I pay my respects to their elders, past, present, and emerging. I further acknowledge the traditional owners of the land on which you are on and pay respects to their elders, past, present, and emerging. And I would also like to acknowledge the Aboriginal and Torres Strait Islander people joining us for the webinar today. So the plan for today is to initially discuss comorbidity, and the main aim is to give examples of treating comorbid substance use and mental health disorders using some common tools from cognitive behavioural therapy. So most of these tools, or many of these tools, you'll be familiar with. And I guess my goal really is to highlight some of the challenges that clinicians face when setting behavioural tasks and ways to work with clients' thought distortions, both related to their mental health and their substance use. I also hope to highlight some issues that can arise when assisting with behavioural activation planning or setting exposure tasks for mental health disorders. So to begin with, when I refer to comorbidity, I'm referring to the co-occurrence of mental health and substance use disorders at the same time in an individual. So obviously there are many types of comorbidities, but that's what I mean when I'm talking about comorbidity today. So rates of comorbidity are high amongst those experiencing a substance use disorder. Estimates from the National Survey of Health and Wellbeing indicate that 35% of individuals with a substance use disorder also have a co-occurring anxiety or affective disorder. You can read a lot more about comorbidity in the current comorbidity guidelines. And so I won't go into it much further today, but it was just to define what I mean when I use the term comorbid. And I guess given the high rates of comorbidity across many different disorders, today I'm going to focus on the common CBT tools that are used when treating substance use and mental health disorders, rather than focusing on specific treatments for co-occurring disorders. So there are plenty of treatments, manualized treatments out there that you would be able to access. And really today, I'm just drawing on some tools that can be useful across a variety of disorders. So we know that the rates of substance use and anxiety disorders are really common, as well as substance use and mood disorders, but also personality disorders or trauma. And many of the tools I'm going to discuss can be used across different settings and different presentations. So there are multiple harms associated with comorbidity, and these include higher suicidality, increased hospitalisation and emergency department visits, increase in other illnesses and other substance misuse, early relapse, as well as a decrease in quality of life and functioning and a decrease in treatment outcomes. And so there's also increased relational distress, as well as, poorer physical and mental health. So again, more details of the harms associated can be found in the comorbidity guidelines, and I recommend you take a look if you are not familiar already. So I guess there are many different types of CBT and various tools that can be used when working with someone presenting with a comorbidity. And today, this is not supposed to be an exhaustive list of those tools. Quite the opposite, really. I'm instead going to touch on some common tools that can be used to assist a client to manage both their mental health and substance use disorder. And many of these tools, as I said, you're going to be familiar with, and I'm going to speak to them. And really just using the lens of comorbidity, I'm trying to take into consideration multiple issues, so the substance use and the mental health, and really just having that lens there to, I guess, when we're visiting any of the tools that I'm going to talk about. So cognitive behavioural therapy for comorbid substance use and mental health disorders. I'm going to really talk about assessment of substance use soon, but when initially establishing working with a client presenting with a substance use disorder, you may require some motivational interviewing techniques. And Dr. Robert Fullerton recorded a really informative and useful webinar for the comorbidity guidelines, which I highly recommend you watch. MI in itself is worth the whole webinar. So let's assume that you've been using some MI techniques and that the young person's wanting to change their substance use, or that the client is wanting to change their substance use. Sorry, I work with a lot of young people, so I'm used to calling clients young people, but obviously you will be using these techniques across the whole developmental span. So I guess just in general, CBT is structured, it's goal-oriented, and it's focused on immediate problems. That's not to say that I would completely dismiss somebody's history, or that I wouldn't want to understand more of what has gone on in their past. But if I'm using some of these tools, I guess the focus really is around what the problems are today. It's designed to be flexible and empathic and collaborative. The goal here is really to tailor the treatment to the client. So I'm quite used to working in research settings where I may have a manualised treatment that I'm delivering, in which case there's less flexibility, because obviously you're wanting to ensure treatment fidelity. But when using these techniques with clients outside of research settings, I do find you can be incredibly flexible and really draw upon different tools specific to that client's presenting issues. So I guess the role for the therapist really is to teach the client new skills for behavioural change, and to assist them in achieving any of their goals associated with controlling their substance use, but also managing their mental health. So specific techniques can vary really widely with the type of CBT used, but typically it includes focus on a functional analysis and some skills training. So I'll get to more on functional analysis in a moment. So I won't go into all the details of clinical assessment here, because I think that each individual or organisation will have their own approaches and will be using their own standardised tool or clinical assessment tools. I'm mentioning this though in the sense that I think it's important to always ask about substance use when conducting a mental health assessment, and vice versa. So if conducting an assessment on substance use, trying to ascertain other mental health issues that may be co-occurring for that individual. You might use more formal tools like the audit or the assist, or you might be using a diagnostic interview, or if like me, you're working in private practice, you may be conducting a comprehensive initial assessment and including some measures alongside your clinical judgment. And I think it's really important to explore with a client what substance use actually looks like in their life. So if the therapist were to ask, do you drink alcohol, smoke, or use illicit substances? And the client responds, well, I drink sometimes. I think it's really important to follow up on what that sometimes means for that client. So recently I was conducting an assessment, and I had exactly this, where a client said to me, oh, I drink sometimes. And when I probed a bit further, they said, well, sometimes I guess means probably daily. It's like, okay. And then I asked, and how much do you drink? And they said, oh, not a lot. I was like, okay, what does that look like for you? And they said, oh, I guess 4 glasses of wine daily, or of an evening. And it was really helpful, I think, for that client, even just to say that out loud. So this was purely just us looking at what their substance use looked like. But for this particular person, they sort of paused and said, so actually, I guess I do drink every day, and I do have, maybe 4 glasses of wine. So maybe that is something that I would like to shift. So again, I just think it's important, because if I had just written down sometimes and a few drinks, I wouldn't really be capturing what that meant for this particular individual. So before I move on from assessment and start talking more about tools used in the treatment of comorbid disorders, one thing I would add, as it applies to both substance use disorders and mood disorders, as well as comorbid substance use disorders and anxiety disorders, is something that we often try to do with clients, and I find really difficult. This is often used in research settings, but obviously also used in clinical settings too. And it's the timeline follow back method of gathering information about a client's substance use. So for those who are not familiar with this tool, it works by asking the client what substances they used yesterday and in what quantity, and then asking what they used the day before and the day before that and the day before that. So initially it's recommended to get substance use for the month, but if used as a monitoring tool, you can ask in reference to what substances they've used since their previous therapy session. And I just find this really difficult to do for myself. And in my experience, clients find it really hard, and especially adolescents. So I know it can be a really useful tool in both assessment and monitoring, but it can also be really tricky for somebody to remember. And I think, but in saying that, I think it has lots of really rich information in it, alongside an opportunity to explore mental health triggers to substance use as well. So I guess I tend to ask people to help me get a snapshot of their substance use since I last saw them by using other apps that might trigger their memories. So, for example, I might ask them to look at their photo app on their phone, or Snapchat, or 1 second every day, or a whole variety of apps. So I would essentially ask the client what they would use daily, and if there's something that they would be able to use to help remind them what it was they were doing on that day, which might help them to remember what substances they used as well. So if you were to ask someone, what did you do 2 Saturdays ago, it's going to be pretty challenging to remember. But if they can flick through their photos and go, oh yeah, there's a photo of me at the beach, oh that's right, I had a couple of ciders with some friends, it's just, yeah, obviously it's really helpful, and many of you would already use these tools, and I was really just making this little point in case anyone wasn't using this, or especially if you're working with young people, I think this can be really useful. So there are, of course, some apps out there that do track substance use anyway. So what I would usually find, once a client's engaged in treatment, I might suggest that they use one of these tracking apps. So the ones I've put up here are just 2. One's called Drink Control and one is Action for Change, but there's many out there, and really it's about choosing one that feels best for your client. I have mixed success here, I guess. I think some will do this really diligently and others just won't ever download the app. So I think, though, the more options that we have to record substance use and keep track of substance use, then the easier it is as well to link in maybe triggers that are associated with a person's mental health. So yeah, I'm really just mentioning these as options. So I'm now going to talk a little bit about functional analysis. And initially, it can be really helpful to start with this to try to understand drug use. But this is also where you can work with the client on their comorbid mental health disorder. So oftentimes triggers for substance use are based on distress. As you're all aware, substance use is often used as a coping strategy for distressing thoughts and feelings. So when purely working on reducing substance use, the therapist won't necessarily be taking into account the function of that substance use. But with a client where you've identified, say, anxiety or depression or trauma as part of the function of their use, then it's really important, I think, to unpack that as much in as much detail as you can. So an example might be if the therapist were to say, so we would have worked through this, the therapist said, when exactly in the past week did you use? The client might say on Friday night, Saturday night, and Sunday afternoon. So where were you? I was at after work drinks, a friend's birthday party, and a catch up with mates. So the next question is why? This is where you might need to dig a bit deeper, and a client may pause here if they haven't connected and considered the purpose of their drinking before. So you may need to probe and ask them to consider what they were feeling and thinking prior to this particular activity. So the therapist might say, why do you think you had a drink on Friday night? And if the client responded, well, I don't know, I guess everyone else was. Therapist, okay, so everyone was drinking, and why do you feel that it was important for you to have a drink? And the client might say, well, I guess I just didn't want to look strange or weird. Okay, so you feel that if you didn't drink, you might look strange or weird. At this point, you might leave it there because if you've been working using CBT tools already, this is where you might jump into a cognitive restructuring task. But if not, you would just continue on with who, and the client might say, well, with my work colleagues, which colleagues specifically. So really trying to glean as much information here as possible. And so what happened, the client might say, well, I had about 8 beers, then I had an argument with a colleague. So the purpose of the exercise really is to delve into the detail of the substance use, really trying to understand the context around using or drinking, and also getting some insight into any unhelpful thoughts that may be maintaining the substance use, but also getting some insight, I think, into unhelpful thoughts associated with their mental health disorder. So in this case, thoughts like everyone else was drinking and I would look weird or strange, that's really useful to make note of, alongside recognizing any unhelpful behaviors that have occurred, like the argument with the colleague. And so we'll go on to talk about what you would then do with those particular thoughts that you've identified as being unhelpful. So most of you will be familiar with the CBT model, but just as a quick refresher. So if you start with the situation or activating event, so in this case, going to work drinks was the situation. And then you're considering thoughts associated with this. I must drink, or people will think I'm weird or strange. This is going to lead to potentially heart racing or other physical responses alongside anxiety or other emotions. And then the behaviour or action is drinking. So you're really helping the client to understand the ways in which a situation leads to thoughts, which lead to a physical, emotional response, and then leading to a behaviour. And so, yeah, as I said, in this case, the after work drinks led to the thought that it would be weird to not have alcohol, leads to potentially increased heart rate, sweating, ultimately anxiety, leading to drinking, and leading to an argument with a colleague. So just assisting the client to see the way the model applies to their substance use and their mental health is really valuable, because it's going to help them to utilize the next strategy of cognitive restructuring. So again, I think just holding in mind thoughts that are both associated with the substance use and also with the mental health disorder. So in terms of various cognitive tools that can be used, obviously recognizing unhelpful thoughts related to either mood or anxiety or substance use or anything else that might be going on for the client. Monitoring those thoughts. So there are loads of monitoring either forms or apps that a client can use. And then you might move to cognitive restructuring, or you might use Imagery. Again, just drawing on a couple of different tools. This is not exhaustive, and most of you will be familiar with these types of tools that can be used. So I guess, and then, yeah, so I'll talk about each of these in a little more detail. I'm also going to talk a bit about practicing some specific CBT tools associated just with substance use, but again, just using that lens of comorbidity. So I think it's really important to explore common thinking errors that help the client to identify their common approaches to thoughts. So looking at these errors, not just from a substance use perspective, but also from a mental health one. So a few examples here might be like mind reading. So focusing on anxiety, the therapist might say, everyone's going to think I'm weird or strange. So we're identifying that as a potential thinking error. It's a cognitive distortion, and it's driven by anxiety, but it's also related to the belief that the client, it is related to the belief that the client knows what others are thinking and that they can read other people's minds. An example of catastrophizing might be that if the client has the thought, maybe I'll lose my job if others don't like me and see me drinking and joining in. So again, anxiety is identified, but also the way that this connects to the client's substance use. So again, just using that lens of looking at both mental health and substance use. A client might blame or deny. So I don't have a problem with alcohol, and again, just helping the client to unpack that thought a little more and dig a bit more deeply into that thought. They might resort to emotional reasoning. So that's sort of this cognitive process by which the client concludes that their emotional reaction proves something is true despite other evidence. So the example might be, I know I need to drink because I don't feel anxious when I drink, but actually that could be true, except that there are other ways to manage anxiety other than drinking. So this belief that I need to drink is actually an unhelpful sort of cognitive process. All or nothing, I can't just have one drink, I've got to have quite a few. Fallacy of fairness. So this idea that this sort of a rational cognitive framework where someone feels resentful, like others can drink and I can't, that doesn't feel very fair. Yeah, so obviously you could work through lots of those different distortions with your client and have them monitoring their thoughts over time, just to, again, be able to unpack those, always kind of looking at it from both the lens of, say, anxiety or low mood or whatever else might be going on alongside the substance use. So again, cognitive restructuring, there are so many different options, so many different forms and apps out there that can be utilised. And really here, I guess I'm just working through this idea of the activating event being the work drinks. The dysfunctional thought is, I need to drink or I'll look weird or strange. And then that led to drinking, which then led to an argument, which quite possibly led to feeling pretty horrible the next day, both physically and then potentially an increase in anxiety, versus actually coming up with an alternative thought there. So not everyone's drinking. I don't need to, I don't think that people are weird if they don't drink or they make their own choices, which could then lead to a consequence of not drinking, which might then lead to the client waking up the next day with more energy and feeling better about themselves and having less anxiety. Again, you can use so many different ways of doing cognitive restructuring, but just a really common CBT tool. And I guess what, again, I just wanted to highlight is looking at the ways in which the anxiety, in this example, the anxiety and the drinking are really intertwined, tackling both the distortions at the same time, I think. And then another sort of more cognitive tool that can be used is that of imagery. So using imagery to picture what it might look like. So the example here might be the therapist could say, imagine you're at the work drinks now and you're not drinking. Talk me through the sequence until the point that you get home. So the client could say, well, I'm standing talking to Ella, I have a soda water in my hand and we're laughing, I hang out for a while. Therapist, and then what? And the client might say, well, I stay for a while and I probably feel really anxious, but then I go home. The therapist, and then what? And the client, I wake up the next day, I feel healthy and I can go to the gym and I don't have regrets about what I said the night before. If the client's feeling stuck in their anxiety, you might need to work with that stuck point. So again, the therapist might say, so imagine you are at work drinks and you're not drinking, talk me through the sequence until you get home. Client, I'm standing talking to Ella, I've soda water in my hand, but I feel so anxious. My face is bright red, my heart is racing, I'm stuttering, I feel sick, I'm panicking. Therapist, you're feeling really anxious and overwhelmed, like the feeling just won't go away. What happens next? I guess I feel sick and I don't know. I guess I just freeze. Hey, you're frozen. What happens next? I guess I eventually walk out and go home. Okay, and then what? Well, I feel pretty bad, but I just go to bed. Okay, then what happens on Monday? I guess I go to work. People might think I'm a bit weird. Okay, so now you're going to loop back, obviously, and use other tools that you've been working on. So you're going to come back and do your cognitive restructuring for that thought distortion, helping them identify it, first of all, as a thought distortion, and then tackling it with some cognitive restructuring. So I think really here it's about, in any kind of imagery work, when you're working with both a mental health and a substance use disorder, is really looking at the peak part that feels really overwhelming to the client. So is it that, that fear that I'm going to just be stuck there and I'm going to just feel like really anxious, it's never going to end, and that's really scary. But actually, of course, it will always end. But just helping them to imagine and imagine then and then and then, but also helping to imagine what it might be like to not have a drink and what that might feel like. And yeah, anxiety probably is going to increase if you experience anxiety and substance use issues. And so, but helping, I think, assist the client to actually imagine things to be different rather than feeling as though they need to drink. and to get through a situation. I'm now going to deviate just slightly away from comorbidity for a second to talk about just some substance use refusal skills. And obviously these are specific CBT skills that are used when working with a substance use disorder. I do want to highlight though the importance of always holding in mind the mental health issues for that particular client. So these techniques might just coincide with general assertiveness skills, especially if working with social anxiety. But so I'll talk these through. Essentially, you're wanting to respond quite rapidly. So a quick response, having really good eye contact, responding with a firm no and not leaving the door open for future offers of substances. And making the conversation brief and leaving if they have to. So an example would be the therapist saying, let's work through how you might refuse a drink. You're going to need to be clear and direct. So, for example, if your friend offers to get you a drink from the bar, you're going to need to respond with something like, no thanks, I'm not drinking. If the friend then persists, come on, just one, no thanks, but you could get me a soda water. Meanwhile, you've got to tell me about how that date ended up the other night. So you're being clear, but you're also making it brief, and you're moving away from that conversation about substance use and you're moving on to something else. A client may also just need to say, if someone is really persisting, especially I think for younger clients, sometimes that can feel really overwhelming. And if people are like, come on, just have a drink or, join in, it is possible sometimes that the client will just have to leave the situation. I think clients might need, it depends on the client, sorry, but some clients might need a lot of practice at this. I think it can really help to play out lots of different scenarios. So I think if a client's really struggling with anxiety, you're going to want to challenge any unhelpful anxious thoughts here too, really listening out for the ways in which anxiety might become a barrier to them using these refusal skills, substance refusal skills. And helping them recognize the ways in which maybe substance use has been a coping strategy for them. So I'll get to sort of more behavioural tools in a moment, but I think, just highlighting here that whilst you're teaching these specific skills on refusing substances, you're also obviously just holding in mind that client's individual experience and whether or not they do have anxiety, for example, and really tackling those unhelpful thoughts that could get in the way. So the next kind of specific CBT tool for substance use disorder I'm going to talk about is just coping with cravings. So I think highlighting for a client that craving is most often experienced early in treatment, but it can continue for weeks, months, years beyond even quitting a substance. It's uncomfortable, but it's really common, and it doesn't mean there's something wrong. And a client should really expect craving to occur and just be prepared to cope with that craving. I think highlighting for a client that cravings are time limited. They will pass. Most cravings will pass within a few minutes. Some might last for longer, but they will decrease. Obviously, the frequency and the intensity of the craving is going to decrease over time. And the less that the client responds to the craving with meeting that craving, so the less that they drink when they have an urge to drink, the less likely that that craving is going to be more intense or last for longer the next time. So urges will sort of occur less frequently over time. And the easiest way to deal with cravings is to try to avoid them in the first place. So this can be done by reducing exposure to triggers, so getting rid of any drugs or alcohol in the house, reducing contact with friends who they usually drink or use drugs with. And sometimes craving can't be avoided, so it's necessary just to find ways to manage that. So there's lots of different strategies. I often will talk to clients about just using pros and cons, so like the pros of having a drink, the pros of not having a drink, the cons of having a drink versus the cons of not having a drink. So actually looking at it a bit more holistically, not just saying, here are the pros to not drink, actually examining it and teasing it out and finding what's meaningful for that particular person. challenging any unhelpful thoughts related to substance use. People are going to think I'm weird if I don't drink. So really challenging that thought, as well as some positive self-talk, delaying and distracting. So if a client can delay for 15 minutes, they notice the craving and then just not responding to it for at least 15 minutes can be really helpful. So I think, yeah, for if, you know, a client might say, look, what's an example? So say you've identified going to work drinks as a trigger for craving. You've explored the thoughts and feelings behind that trigger. The cravings are naturally going to go, but let's say that you're at work drinks and you get the craving. What are you going to do? And so the client might say, well, I'm going to distract myself. I'm going to go chat to this particular person just for the next 15 minutes. Or maybe I actually just need to go for a walk around the block and then I'll come back to the drinks in 10 minutes or so. It's really worth thinking about how to manage that craving in the moment and what's actually going to work and be acceptable for that particular client. I think like another example might be for someone with low mood. So say the client says, look, I noticed I felt really down on Tuesday night and I just immediately went to open up a bottle of wine. And the therapist might say, okay, so what did you do instead? The client, well, I remembered what you'd said and I told myself to recognize the craving and my feelings and to distract myself for at least 15 minutes and then reassess whether to open the wine. And then the therapist might say, so then what did you do? Well, I went and had a shower. I sent a message to a group chat I'm in and I sat and watched reality TV while I was in the chat. What happened to the craving? Well, first it was really intense in the shower. I just was thinking, look, I'm just going to go have a glass when I get out of here. But then the chat actually distracted me enough and it lifted my mood. So I didn't really have the urge to drink as intensely. Obviously, this won't always work, but just reinforcing any time that a client is able to delay the craving, even if they only got through the first 15 minutes, I think it's still really important to acknowledge that they got through that 15 minutes and just working on a plan for the next time they do experience the craving. Sorry, and I just realized I didn't mention riding the wave of craving. So again, just that can often be imagery and just visualizing what it might be like to be surfing a wave of the craving and letting it kind of rise and peak and then it will come down. And yeah, assisting the client to build confidence in themselves that they can get through this. So I'm now going to discuss some behavioural tools that can be useful. So again, this is not exhaustive. It's merely an example of some useful strategies when working with someone with a comorbidity. Again, you'll be familiar with many of these tools. So I often use behavioural activation and I often use some specific tools from the Behavioural Activation for Depression Revised Manual by Carla Jouet. So essentially using a tool like behavioural activation can be really useful when addressing obviously both substance use and depression. And when using this tool, I think it's really important to focus on different values within life areas and creating activities from this. So for example, here the life areas I use are usually relationships, school, career, leisure, mind, body, spirituality, and daily responsibilities. Then looking at a value, which is an ideal, quality, or belief in a certain way of living your life. So example, honesty or compassion. And then scheduling, monitoring, and rating the importance and enjoyment of activities. So just a note on activities, they really need to be developed using SMART goals. So specific, measurable, achievable, relevant, and time-bound. And I think, you know, all of these things, this particular strategy of behavioural activation is so common when working with a mood disorder. And the main thing I want to highlight here is just that it's really important that the client, the activities that the client comes up with are not going to be triggers for substance use. So you're really wanting to examine all of the activities that come up and just making sure that they're not actually going to become barriers to abstaining from substances or reducing substance use. So an example here might be the therapist might say, let's focus on relationships and explore what you value there. The client might say, I guess I just want to feel heard and seen, and I would like to be able to see other people too. So the client or the therapist might kind of conclude from that, that sounds like connection is really important to you. Is that fair to say? And the client will be like, yeah, it is. And so coming up with activities. So with someone with low mood, they might say, well, look, I really want to, use connection. So I'm going to text a friend. I've been kind of worried about them anyway. And so great, that's a really good way to connect with someone. It might seem small, but actually if you build in lots and lots of activities across the course of a day, you're increasing things that are going to hopefully improve a client's mood, and you're decreasing time to use substances or to focus on substance use. Again, just holding in mind that, you're trying to elevate a person's low mood here, but you're also really holding in mind the substance use. So keeping that lens of comorbidity. So for example, if the client were to say, well, to meet my need for connection, or to meet that value, maybe I'll catch up with a friend in that park down the road. And the therapist might be like, well, that's a really great idea about catching up with your friend, but let's not forget that you've mentioned that you had been drinking there recently. So do you have some other ideas, something else you could do with that friend that doesn't involve going to a place that might trigger you to want to drink or use other substances? I think the next step of behavioural activation really is just to have a client kind of plan out when they're going to do each activity. So you're really wanting to ask them to look across the different life areas and different values, come up with a heap of activities, all of which you've examined to ensure they're not going to get in the way of substance use goals. And then you want the client to write down when they've done that activity, when they plan to do it, and then highlight when they do it and rate how important it was to them and how enjoyable it was. The real goal here, I think, is just to provide structure and meaning to the day. Clients getting active, they're aligning their activities with their values. So it's not just, I'm not just doing things for no reason, I'm doing them because they mean something to me. It's directly working on improving their mood, but also hopefully reducing their substance use. And I guess the thing is with these is, how do you ever get a client to complete these? And I would say with great difficulty. So obviously these are not fun monitoring sheets to fill out, I don't think. I mean, maybe some people enjoy them, but I don't, and I haven't found many clients who love filling them in. But again, this is where you can just be creative, right? And have a client maybe take a photo of the activity they're doing and just jot down somewhere in their notes section of their phone how enjoyable and how important the activity was to them. So yeah, coming up with different ways that you can do that with an individual. The next sort of behavioural strategy is that I'm going to talk about is using an exposure hierarchy, which is obviously such a common CBT tool to use, and particularly for people experiencing anxiety. So the idea being that you're asking the client to generate a list of avoided activities and how anxious the client is to try these, and ranking them in order from the least feared to the most feared. And there's so many examples of exposure hierarchies, and I am really mentioning it here for the sake of considering issues that may arise when using this with a client who has a substance use disorder as well. So it's important that all the activities, again, are assessed for whether they're a high-risk situation for substance use. So you really want to make sure the client's prepared that if doing a speech at a colleague's leaving party, that they've got plans to manage their substance use too. So that might be coping with cravings, social support, like they're going to do this and tell a friend that's going to be there to help them out and check in on them and see how they're going. And also making a plan. How are you going to get through this particular activity or step on your step ladder? Not only how are you going to manage the anxiety, so the thoughts that might come up for you and the physical sensations, but how are you going to also manage any cravings that might occur at the same time? So again, being really careful that none of the activities on the step ladder are going to be direct triggers. This is tricky because obviously anxiety is often a direct trigger for using substances to cope. So I think really it's about just saying, well, we're going to try to minimize this person being in a situation that's going to be really challenging around their substance use. So yeah, I mean, if someone says, well, I'd be kind of anxious to go out to a club dancing, we might want to just wait until they've had a good period of not using substances and until they feel really confident that they could go into an environment like that where so many people would be drinking and using drugs. So just briefly, I'm going to talk about some distress tolerance tools. So obviously, there are, again, so many out there, and this is just a brief example of some. So throughout treatment, you're going to really need to just build upon their distress tolerance skills alongside the coping with craving and the substance refusal skills. So using breathing techniques like breathing in deeply, counting to 4, and then saying calm or relax before slowly breathing out, and repeating this and practicing it throughout treatment. And practicing it for both managing cravings for substances and also managing anxiety or low mood or whatever else, stress, whatever else might be coming up for that client in their mental health sphere. Using grounding exercises like noticing their senses, so 5 things they can see, hear, feel, taste or smell, noticing all of the blue things in the room, things that are really going to just help to bring them back into the moment and away from any overwhelming or spiraling thoughts. So reinforcing that these techniques not only are used to manage the anxiety or the low mood, but also to manage any cravings that might be coming up. So finally, just a note on relapse prevention. So another tool commonly used in CBT treatment for substance use disorders. So working with the client though on identifying high risk situations for substance use, but also high risk situations for a decline in their mood or an increase in their anxiety. And knowing that substance use and mental health are so intertwined, so really assisting the client to recognise this and the way that it plays out in their own individual life. So an example here might be the therapist could say, in the past, you found attending a friend's wedding to be a challenge in sticking to your goal of not drinking. And also you found it to be a trigger for your anxiety. So are there other situations you can think of that stand out as being triggers? So again, just highlighting for that client the way in which, yeah, it's a trigger for your anxiety. And then understandably, if you're using alcohol to cope, it's going to be a trigger for a craving for alcohol. So the client might say, yeah, look, I think any event at a pub, like a friend's birthday, is both going to increase my anxiety and my risk of drinking. Okay, great. So let's prepare for those situations and make a plan. Okay, so the client might say, well, I think if I just go with my substance refusal skills, I'm clear, I don't want to drink, and that's going to help. And I'm going to try to make sure I'm always at those events with my boyfriend or a close friend who know that this is something that I'm working on and wanting to avoid. Then I guess challenging any unhelpful thoughts that might come up about people judging me for not drinking, and using some distress tolerance skills in the moment, grounding myself, reminding myself that I'm here in this moment. Therapist would say that sounds like a great plan. And if you have a craving, utilising coping with craving strategies as well. So just, yeah, planning for these potential triggers. I think it's also helpful to think through some potential emergencies. And by that, I mostly mean major life events. So changes in a client's life can be really unsettling, obviously. It can lead them to consider using drugs or alcohol. So things like social separations, like a breakup or a close friend moving away or the death of a friend or a family member. Health issues, new responsibilities, new jobs, adjustments to new situations, moving out of home, moving somewhere else, and any work-related events, so stress at work or financial issues. So just really, it's really about just recognising those with the client, what might be a problem, and then coming up with a plan. Also recognising that not all life events are negative, so even positive ones can be a trigger. So yeah, a new relationship might be a trigger for someone to be using substances more, or a new job. And so, yeah, actually an example would be this client that I'm using, where they are finding work drinks to be triggering. They might have that under control now, but then starting a new job, they might start to have some more of those thought distortions around, I need to drink to fit in. So just highlighting that for that client so that they just kind of hold that in mind as these life events do happen to them. Also, major events that can happen to others that are close to them can also obviously be triggers too. So stress for family members can be a problem that might increase the client's own mental health issues, which might increase their substance use. I think finally, really just highlighting again to make a plan with the client, but then coping with a lapse of either substance use or their mental health issues. So reminding the client it's not a roadblock, it's just a speed bump. You're not back at the start of the journey, you're merely getting yourself back on the road, and really reinforcing the skills that they've learnt along the way, addressing both substance use and also their mood reduction or increase in anxiety simultaneously is going to be really important. So as I mentioned, this really was just a snapshot of some CBT tools that hopefully you might find useful. I really think the main take-home message is always to look through that lens of comorbidity. So holding both substance use and mental health issues in mind when working through each problem, and using the tools and being flexible, but using those to essentially manage these kind of issues that arise both in the mental health and in the substance use spheres. So thank you. If you have any questions, feel free to email me, but I will be able to answer some of those now. Thank you.
Thank you so much, Jo. That was fantastic. We have had a lot of comments and questions come through as you were talking. But first of all, let's get started off with a question that I have actually about if you have any advice for anybody who's just getting started with CBT, any tips or tricks that you might suggest?
Yeah, I guess when thinking about utilising CBT, when working with a client who's presenting with comorbidity, with substance use and another mental health disorder, I think just starting with the model, the CBT model, and helping the client work through recognising activating events and then thinking about their thoughts and the way in which that impacts their feelings and their behaviours, and really trying to hold in mind that comorbidity lens. So really, I guess, asking the client to think about the ways in which these things are interacting, and yeah, I guess really just starting with the model. And I think that could be helpful too for the clinician in terms of being able to always hold that in mind for them as well. I think it can be tricky to not get distracted and pulled one way or the other. But yeah, if you're actually just kind of starting with some of that psychoeducation around CBT and how that applies to that specific person, I guess that's kind of where I would start.
Just trying to pick up my microphone here. No, thank you. And I think, you know, some of the advice and the really practical ways that you explained a lot of the information in your webinar was really useful. I think a lot of people will find that really helpful. Some other questions that have come through that we won't be able to get through all of your questions, everybody. So I'll just say up front that the questions that we can't answer today, I will send them through to Jo, and we will post the answers on the website and send everybody an email who's here and letting you know when those are available. So please check back if your question hasn't been answered. So a question that has come through about assessment of, I think for drinking in particular, whether or not you're familiar with Grog app or Finish method. And I think this was in relation to some of the memory apps that you were referring to, whether is that being used to collect information or as a memory jogger, or are you assessing it? And Kath is unmuted, so I'm thinking you're trying to add something here.
No, I was just going to say, I thought that in reading those few questions around that, it did strike me around the like there being lots of different methods of collecting information sometimes, and I guess I was wondering of Jo, like, how do you get that balance right? Because there are sometimes longer assessments with more detailed information, but you've also got that time pressure of doing the therapeutic work in there.
Yeah, and I agree. And thanks, May made a point there as well about just ensuring that you're asking a client about standard drinks. And that's a very good point. Apologies that I wasn't clear about that. But yeah, I think that obviously the timeline follow back, it is a longer assessment, and it can be tricky. And I think, Kath, sometimes it really is dependent on the client as well, and being flexible. And if you're working with, I don't know, sometimes a young person and they're just not interested in really talking about their substance use, then I agree, maybe a shorter method is useful. I think, though, when you have someone who's presenting in this, and certainly if they're saying, look, substance use is something that I'm wanting to work on, and this is problematic for me in my life, doing that really detailed, really trying to understand how much a person is using is so important, because not just for the clinician to get that sense of what might be happening, but I really think just that monitoring, or that kind of understanding of how much use is occurring for the client, can be a tool in itself to kind of help to action change, or just highlight for the individual that, oh, hang on a sec, maybe this is more problematic than I'm admitting to myself. Yeah.
I think that actually feeds into one of another question here, and I don't know, actually, I don't know if it does. You can probably answer that better than me, but would you say that there are any, or are there any recommendations you have for clients who may not have insight into the substances that they're using, or how much or how often, or yeah, I know you were saying earlier in your webinar that just talking about it does give some insight, but is it possible to kind of, pull that out if there isn't that insight?
I think that's a great question. I think, I think that you can. I really do think that using, again, coming back to that cognitive model where or maybe a functional analysis actually is often the place where you can get that kind of richer information. You're asking these specific questions that are hopefully really helping the client to identify for themselves that, oh, hang on, maybe this is a problem. Sometimes as well, I didn't mention this, but sometimes just using some basic statistics around how many people do drink at what frequency. And certainly I think, again, for younger people, I find that so useful and can be really eye-opening when they don't have insight, because often you might just be, all of your friends or your peer group might be using substances at a similar rate to what you are, similar frequency or quantity. But actually, when you compare that to, say, data from the National Household Survey, then you would actually find that, like in your peer group, maybe substance use is really high and prevalent, but actually in comparison to your peers and a more general kind of population, it can be really eye-opening, I think, for some people if they do have a substance use issue. So I think that you can use CBT even if someone doesn't have insight into their substance use. I think you can, again, the motivational interviewing is really helpful here. And obviously I didn't go into that too much. So I would really recommend watching Robert's webinar, because it was fantastic. So if you haven't already, I think that would be helpful.
Yeah, that was a good one. But, so is this one. I think we are running out of time. I'm really keen to shove in one more question if we can, but don't feel pressured to answer it quickly. And if we can't answer it properly, then of course we'll post it online. Just quickly, would you say, are there any recommendations for clients who may be using substances while they are in isolation? So for example, if they're only drinking or smoking when they're at home by themselves, but not at social events?
Yeah, definitely. So I would be, obviously, I guess it would depend on the reason why they're using those substances. So really trying to, again, looking through that comorbidity lens, so kind of thinking about, is this someone who's drinking in isolation because they're feeling really lonely and their mood is really low, in which case, again, I'd be using those kind of various tools from CBT, but maybe using a focus of behavioural activation, trying to look at ways in which we could help this person increase their mood by engaging in other things that are more meaningful to them. But if instead it's actually because they're experiencing a lot of anxiety, and so they're actually just drinking at home in isolation or using substances in isolation because they're feeling really anxious, then you'd be using kind of a different sort of framework, I guess, from within CBT, but different tools. So yeah, I guess it would depend. And again, coming back, I think to the functional analysis would be helpful there to really try to help the client identify what are the reasons why they're using these substances, and how is this connected to their other mental health more broadly.
Yep. Okay. Well, thank you. Some really useful and practical tips and suggestions there. So I know we haven't got to everybody's question, and I'm sorry about that. And I know people are leaving us even as I speak. But just to thank you again, Jo, and quickly put up the guidelines that you mentioned, and of course that are what this series is all about. If you want to find out more about these, you can do that at our website, including download a copy and find out more about the online training program. Thank you again, everybody, for having joined us for the webinar. If you are interested in viewing this recording or passing it on to somebody else, or registering for our upcoming webinars, having a look at our library of previous webinars, you can do that at our Comorbidity Guidelines website. The next webinar is going to be on the 26th of May, and that is going to be on managing symptoms of eating disorders. Until then, thank you again so much for joining us today. Thank you again, Jo, and please enjoy the rest of your day, everybody.
Thank you.
Thanks,
Chris and Erin and Kat. Bye.
Bye.